I'll just show you, take you through one case actually only, and which is kind of a very typical presentation. This is 53 years old female patient presented in September 2016 with difficulty in vision, pain, redness for about 20 days before coming to us. There was no systemic problems, no family history of glaucoma, but she was actually diagnosed glaucoma elsewhere 6 months back and was put on some anti-glaucoma medicines. But when we did her examination, we found that the laser iodotomy was not done, and visual acuity was hand motions in the left eye because probably she had recovered from an acute episode, and the right eye was good. So we did laser iodotomy, both eyes, left eye, then the right eye, and then we kind of monitored the IOP. And as you can see, the IOP goes from 26 to 18, it gets controlled, but somewhere down the line, her requirement for medicines goes up. So laser iodotomy clearly is not being very effective here alone, and we need to do something more. So she was on systemic therapy as well. And this is when this picture was taken after laser iodotomy. You can see that laser iodotomy is patent in both the eyes. And this is the left eye. You can see that there are some good signs here of glaucoma, which you should not clinically miss. Basically, you can see the iris is a little dilated and is also not actually very round. You can see there's a little bit of deformity here. And you can also see that there's an iris atrophy here. And this is the laser iodotomy we have done. And you can see the angle is still, the AC is still shallow, central, as well as the peripheral angle is very shallow. And you can see there's a significant cataract, and if you look more carefully, there's a bit of a few opacities in the cataract in the subcapsular. So there's what you call a glaucoma flecken, which happens after acute episode. So this patient actually had a lot of angle closure evidence. You can see this is a little more enhanced and magnified. You can see some dots here. So these are the glaucoma fleckens here. So gonioscopy was still not, even after laser iodotomy, you can see the angle is not very well opened. There may be some openings in the superior angle, but I think most of the angle is still quite narrow. And this is again after, this is even after indentation. You can see some opening there, but you can see there's a lot of pigmentation there, maybe a few synecdoche there, but the angle is not really very openable in this. This is the optic disc appearance at that time. You can see the right eye looks fairly good, but the left eye, you can see there's a significant disc damage there with peripapillary atrophy is there. She was not very good in doing visual fields. We tried a few times, but we didn't really good anything. So we looked at the OCT, which kind of is more realistic as compared. If you compare the pictures with the disc findings and the overall clinical picture, I think this is a little more realistic than visual fields in these patients. So this is a post-LI patient, poor IOP control, multiple drugs, and what do you do next? So options here again are we do trabeculectomy, we could do combined surgery, or we could do just phaco. And since I have a little predisposition towards phaco, so we did a phaco for her. So the biometry was, the axial length was a little shorter. The lens thickness is on the plus side, not too much. Anterior chamber depth is not bad either. So one could have actually done any of the three choices here, but then I preferred left eye phacoemulsification with IOL implantation. And this is how the post-operative course is. So immediately after surgery, the pressure was a little high, which tends to be high in these patients, and you cover that up with some oral therapy, but gradually you take them off, and if you say about 9 months down the line, the IOP is 14, and she's on 2 anti-glaucoma medicines, latanoprost and timolol. So I think that is a very good control, glaucoma control in this patient by phacoemulsification. So thank you very much. So any questions on this? And if you look at the visual acuity, one presentation counting fingers, now 618, and IOP is good. So I think we are in a fairly good situation as far as this patient is concerned.